Welcome to AETCM, the emergency medicine channel. Shall we start, sir? A 65-year-old male came to ER with complaints of chest pain after ingesting a fish bone 2 days back. On initial 10-second assessment, airway was patent, speaking in full sentences, no stridor, hoarseness or drooling. Coming to breathing, respiratory rate was 20 breaths per minute, SpO2 96% in room air. On chest auscultation, it was bilaterally equal and clear. No crepitus or any on palpation, no subcutaneous emphysema. Coming to circulation, pulse was irregular, heart rate 112 beats per minute, BP was 120 by 80 mmHg. Patient was immediately connected to cardiac monitor, which showed narrow QRS tachycardia with absent P waves and irregular R2R intervals. IV access was secured, ECG was taken, which showed absent P waves, irregular RR interval with varying heart with the rate of 110 beats per minute.
110?
Yeah.
110?
110.
Oh.
Sorry, 110, sir. So, since the patient was stable, we initiated on injection amiodarone 150 mg stat followed by 1 mg per minute for next 6 hours. Coming to disability, GCS was 15 by 15, exposure afebrile. Adjuvants to primary survey, we took a CBC, CRP and ABG. CBC, CRP showed total counts of 15.8, HP of 14.7, platelets 3 lakh, CRP was 55.2. Coming to
this
ABG.
patient, you told on your respiratory system examination, non-respiratory breathing examination, you told there is no subcutaneous emphysema. Why did you mention that point there? Like, what was the importance of that point?
Since the patient had an history of ingestion of a fish bone, if there is any perforation
Where?
in the esophagus or
No. So you are looking for
pneumomediastinum. Yeah.
What are the other conditions in which you will get subcutaneous emphysema?
Pneumothorax,
Pneumothorax.
tracheobronchial
injury, yes. So you can have, basically it is a air escaping from a hollow viscous, right, which is then connected to subcutaneous space. So you can have that in airway, you can have it in breathing.
Right.
So in airway, in our condition it is a bit serious, but the most important condition which it is life-threatening is in airway. There are 2 reasons for it becoming life-threatening in airway. What are those? Why it is life-threatening in airway part, subcutaneous emphysema?
difficult.
One is it makes the intubation difficult. That is true. Second thing, not only difficult intubation, if it is a difficult intubation and goes to failed algorithm, there won't be any landmarks for you to identify and go for a safe crook. It becomes a much more blind technique. Okay, since air is below, when you palpate, you will be getting the crepitus rather than the body landmarks. So it makes the intubation difficult, and it makes, if it is a failed airway, further management of the airway difficult. That is one thing, true. But what is the most, most devastating complication of a subcutaneous emphysema in airway?
Tracheal fractures.
Yeah, not fracture, tracheal
Injury.
avulsion. So here the larynx is now protected with cartilages. So it's very unlikely that larynx will have fractures. Larynx can have fractures, but it's that much of severe injuries. But what happens is that from larynx to trachea, there is now your C-type cartilages are there, and the trachea is non-protected in the back. So in case of like pull injuries and all, when there is significant shear factor, the trachea can be partially avulsed from the larynx, but still kept in place due to the C-type cartilages. These patients will be leaking a lot of air, so their subcutaneous emphysema will be very rapidly spreading. They will have puffy face, puffy lips, the airway will be, size of mouth opening will be reduced, and there will be, eyes will be popping out, may have decreased vision due to edema over the eyes. All neck swellings will be covered up because there's a large volume of liposuction. the natural instinct will be to intubate these patients. But it's very important to identify whether they are having a partial avulsion. So easiest thing is to, best thing is to palpate the larynx and see whether the patient is having any tenderness. If laryngeal tenderness is there, we should suspect laryngeal fracture, look for pelagic crepitus. But if it's not there, you should suspect a below larynx tracheal injury. In that case, intubating can have complete avulsion of trachea. So, in such a cases, ideal will be a awake intubation with the bronchoscopy assisted, so that you can visualize how much of the trachea is in place, and if possible place a smaller size tube and then go for a tracheostomy. Because rather than a tube placed supraglottically, if you are like from the larynx and tracheal level, if the injury is there, it will be much more better to go for a tracheostomy. But tracheostomy is never going to be a ER procedure. So your idea will be to go for a awake intubation, use bronchoscope, assess the lesion, see whether active bleeding. If nothing, go for a smaller size tube, like 6.5. So that the tube passage will not drag the trachea down, shearing it from the larynx. Because once it happens, trachea and larynx is now two separate entities. You don't have any connection to thread. Understood? Okay, so that is in airway. Other condition in breathing can be due to pneumomediastinum and pneumothorax, isn't it? So in trauma, it can be both. It can be esophageal perforation, it can be posterior tracheal perforation due to contusions, and it can be due to pneumothorax. Okay. Here, why did you suspect pneumothorax in your primary survey itself?
Because he was having severe chest pain radiating to back.
Yes. One is time. It's already been 2 days. So, whatever perforation, if it had been there, the air must have been leaking out slowly over last 2 days. So, possibility of pneumomediastinum was very high. Second, patient classical history, central chest pain, diffuse central chest pain without radiation, isn't it? Yes. So, you look for pneumomediastinum. Now you came up and saw that patient is having atrial fibrillation, right? Atrial fibrillation. What do you think is the cause of that atrial fibrillation?
From the history, we got to know that patient did not have any previous AF or previous cardiac history. So it was a new onset AF.
Correct. So what could have been? You are in your primary survey.
One
so
is
what are the
if there is a foreign body and if it is there is inflammation blocking the esophagus, if he take anything, he can aspirate and cause hypoxia. That can lead to AF.
So hypoxia or tracheal injury causing LRTA features causing hypoxia AF. Okay, what else?
If the perforation causing any pericardial effusion or pneumomediastinitis also can
cause AF. These are the most common things we are expecting in this patient, isn't it?
Yes.
What else? If something is stuck in your esophagus or throat, what will you do?
Cough.
Cough is trachea. What will you do?
Gag.
And try to vomit out. Causing? Esophageal tear. That is true. That is mechanical. It won't cause AF. 2 days you are trying gagging, vomiting out. When you vomit, what is getting lost each time?
Potassium.
Hypokalemia can cause arrhythmias. So that is another thing that you need to think about. Okay, so anyhow, you go to your AF. You have your list of causes for AF. Okay. Now, what type of AF is this?
The paroxysmal.
Paroxysmal AF. Correct only. Like, is it stable or unstable?
Stable, sir, because there was,
Okay. So even though patient is having chest pain, it's not a cardiac chest pain, right?
Not ischemic.
Okay, so it's a stable AF. So it's a AF with fast ventricular rate or control ventricular rate?
New onset AFs.
New onset AF, true, but is it fast or is it controlled?
It was always below 150. Rate was always below 150.
What is the cutoff for fast ventricular rate AF?
More than 120.
More than 120. So anything less than 120 is controlled, anything more than 120 is fast. So how much did your patient have?
Initially, it was less than 120 only.
But was it fluctuating more than 120 or always kept below 120? Like, are we dealing with a controlled ventricular rate or are we dealing with a slow AF with maybe a rate of 120, 130?
When I was monitoring, it was below 120 only.
Okay, below 120. Does that actually make any difference in management in ER?
Initial management in ER is always rate control, sir.
Why?
Because the symptoms are due to increased rate.
Okay, basically you are saying that instability of AF will be due to the rate induced, right? So what happens with AF? So AF of 180, 190, what is happening there?
Patient can go to hypotension.
Why?
Because stroke volume reduces and...
So improper filling. First of all, now atrioventricular dissociation is there in contraction, isn't it? So 30% of atrial contraction filling of LV is not happening. So that is 30% reduction in stroke volume. On top of that, there is an uncontrolled heart rate. As heart rate increases, your stroke volume decreases. Because reduced filling time. Because of this, patient goes into severe hypotension and all other symptoms are hypotension or poor perfusion induced.
Coronary perfusion also reduces, can go into ischemic events or any cardiac failure.
Correct. So all this is due to decreased stroke volume. So your idea as an emergency physician should be to improve stroke volume. That the easiest way to do that is to control rate. So why not go for change in rhythm rather than rate? You can control rhythm now. Like you are given amiodarone here. What is amiodarone? Is it a rate control drug or is it a rhythm control drug?
Both rate and rhythm control.
Rhythm control drug and cardiac conduction blocker. But why did you give amio here? Why not give dilsum or diltiazem or metoprolol? Why not a heavy nodal blocking agent?
Since the patient was stable and his BP was stable and we did not...
rhythm ablation. Okay. Is there any right approach in ER? Like, should ERB only be like rhythm control or rate control, something like that?
Rate controls.
Okay, so there is this study 2000, I think 2012-13 times. So it's a RCT in New England Journal, which basically compared between rhythm versus rate control outcome in paroxysmal AF patients. And it found that mortality benefit is not there for both the category. You do rate or rhythm control, mortality is fine. But morbidity is more associated with the amiodarone, right? Rhythm control drug. So rhythm control drug given patients had multiple episodes of hospitalizations for further worsening and conditions, but not mortality benefit. So because of that is why all ER guidelines, like you take AHA, you take ESE, everywhere in ER guidelines they insist on rate control rather than rhythm control. But it's not like rhythm control should not be done. Rhythm control can be done. But in ER viewpoint, if you want to stabilize a patient, rate control is more than enough to stabilize the patient. Okay. In this, you gave amiodarone. So, what is the dosage and how do you give amiodarone for AF?
Initially, bolus dose 150 mg was given. Then followed.
When you say bolus dose, how long is the bolus?
Within first 10 minutes.
10 to 15 minutes is amiodarone bolus dose. Okay, followed by?
1 mg per minute for next 6 hours.
Yes, and
Then followed by 0.5 mg per minute for next 12 hours. 18 hours.
18 hours. So we are giving 24 hours, round the clock infusion. Okay. So all these infusions, so that is a paracetamol, everything is 24, 23 hours is what we give. So 6 hours 1 mg per kg, 1 mg per kg, and another one is.
Sir, 0.5.
First 6 hours is
1 mg per minute.
It's followed by 0.5
mg per minute.
kg for 18 hours. Okay, so when you give amiodarone, what are the contraindications that you should look into? For example, for this patient, before giving amio, what are the other contraindications you should have looked into?
Whether hypotension should be,
No, hypertension.
because patient
Amiodarone itself can cause hypertension. That is true. What else?
any thyroid hyperthyroidism. Severe hypothyroidism patients, if you give bolus dose of amiodarone, it will worsen the patient. But is that a relative contraindication or absolute contraindication? Relative only.
Relative. So if patient is having instability and you want to give amiodarone, you can, but then you have to supplement patient's thyroid levels also. Okay. So you are given amiodarone and corrected it. If at all you are giving AV nodal blocking agents, what are the available AV nodal blocking agents for you?
We can give injection metoprolol 5 mg every 3 to 5 minutes. Maximum up to 3 doses can be given.
Okay. And
Then we can give calcium channel blockers like injection diltiazem 12.5 mg can be given.
so beta blocker and calcium channel blocker can be given. Okay. So you have managed your AF with amiodarone. After amio infusion, patient's AF reverted back to normal. Sinus rhythm.
Rate control.
Rate control was achieved, but rhythm persisted.
Persisted.
Okay. Now what happened?
Further, we went with the further. So coming to sample history, a 65-year-old male, known case of type 2 DM hypertension, came to ER with complaints of upper chest discomfort and pain, which was sharp, non-radiating, increasing on swallowing and deep breathing. Patient had history of bone ingestion 2 days ago, for which patient had mild discomfort initially, worsened over past 24 hours. Now has persistent pain, mild odynophagia and mild dysphagia. No history of cough or breathing difficulty, no history of vomiting or hematemesis. Even after giving initially when he came, we had given injection PCM 1 gram IV stat also for the pain, but pain was persisting and we hiked up the analgesics. Then we went ahead with the further investigations, got an X-ray chest, neck and chest to look for any foreign body or air in the mediastinum. There was no foreign body or air in the mediastinum. Then since the patient was complaining of chest pain, we had taken a drop by point of care also, so that was negative. Then we went ahead with the CT chest plane and contrast, which showed a linear radiodense foreign body noted in the mid-esophagus penetrating the left anterolateral esophageal wall at D8 level. The tip of the foreign body is seen adjacent to the coronary sinus without any pericardial effusion or pneumomediastinum. No obvious esophageal collection or pneumomediastinitis at present.
But it's penetrating foreign body.
Yeah, penetrating foreign.
Okay. So such a patient comes to you. For example, the patient is coming to you and telling that I was chewing something and suddenly I felt like I have something stuck inside my esophagus. How do you proceed?
Sir, if we are suspecting multiple foreign bodies or a penetrating foreign body or a big bolus of food, then immediate endoscopy has to be taken because it can be life-threatening.
Okay. So, intervention gastro call up for endoscopy, that is true. But don't you want to know what is causing? Like for example, patient comes and tells you, patient after exercising made a shake with multiple blended fruits and nuts and all those things. And after drinking it, patient feels that something is stuck in the esophagus. Now you don't really know what is there, right? It can be fruits, it can be like parts of the shake, or it can be nuts, isn't it? So are you going to call for endoscopy or are you going to do something?
Only for radio opaque things we can do a CT, sir. If we know the patient has...
True, all these are organic things, so CT may not show. But what is the important thing?
if the patient ingestion of coins or something.
No, metallic things is obviously is going to be
same.
shown up, but in these cases, like your born patient gives history that I swallowed a chicken piece. Or unknowingly swallowed. I was sucking on it, suddenly it went down, or it's a big fish bone. Obviously, OGD has to be done, but going for a CT plane will help you localize where it is.
Yes.
For example, the bone can be in a transverse position or a longitudinal position. So the person who is going to do the endoscopy can understand whether they can take this procedure from ER or plan it in a OT settings, whether it can be tried or not. For example, things can go in transverse position and lodge into esophagus. Now, the both end of the foreign body is lodged into esophagus and stuck there. Now, this has very good footings. So, you need to dislodge one end to pull it out. And while doing that, you may cause perforation. So, knowing that is actually better. So, unless it's a upper esophageal obstruction, we ideally should go for a CT esophagus or CT neck and thorax plain, not contrast, plain. So that will give you any pneumomediastinum. So if perforation is there, you know it's already bad, and you can identify the lay of the thing. So what I earlier told was one of the cases that I saw. The person mixed a shake and there was a walnut in its entirely in it. So this person drank the shake, she got the foreign body, she just swallowed. So it was an entire walnut. So walnut is basically around 2 to 3 centimeters, right? And this thing fit into esophagus perfectly like a circle. So it was not like upright. It was in. So in CT esophagus like this, then esophagus bulged out and then came back. So patient was complaining of severe chest discomfort, like something is actually stuck there because this is. And they had to first destroy the walnut, push it into stomach, then take it out. Because it was not able to, they can't take it from the esophagus. So imaging at these situations is really helpful for them, especially if it doesn't pose any threat to patient's airway. Patient's airway is fine, patient is sitting there, patient is talking, and there's no hemodynamic instability. We have enough time to get a CT and get it done. Okay. Now, you are called up, so they have come, they have removed the fishbone or foreign body, and they are like, there is nothing from gastro side. How do you dispose these patients? Do you dispose these patients? Do you discharge these patients?
No, we'll have to take a repeat CT.
Yeah. So a repeat CT for complete removal of foreign body and any perforation that has happened. So you need to keep the patient in observation for 6 to 8 hours, then repeat the radiogram. X-ray is fine, and look for pneumomediastinum. Or if your person who has removed is not sure whether he has removed fully, you have to go for CT. But after that, you can discharge these patients. But when you discharge, what will you do? What will you provide?
Avoid eating.
Avoid eating is there, but some anesthetics agent so that patient will have reduced pain there. Then antibiotic. Because if at all there is a small perforation which the muscles have closed up, patient can still develop irritation and inflammation. So to prevent further infection, you can give an antibiotic and send the patient. Okay. Anything else happened in this patient?
No, sir. Post endoscopy, we took a repeat CT which showed no residual foreign body, no signs of esophageal perforation, no mediastinitis or error collections. Now patient is under observation.